Welcome to Healthcare by the Numbers, a podcast that uncovers what's driving healthcare transformation. Join us each episode as Caravan Health leaders interview the brightest minds inspiring healthcare innovation and discuss the numbers which have shaped their thinking.
Well, hello and welcome. I'm your host, Greg Paris. I'm the Vice President of Customer Success at Caravan Health. And this is Healthcare by the Numbers, a podcast that explores the numbers driving change in our healthcare industry. From payment model innovations to hospital closings and anything and everything in between, this podcast gives us a chance to speak with the brightest minds in healthcare to help us tackle the numbers which affect us every day. At Caravan Health, we specialize in helping community health systems transform their care delivery. And today we're absolutely delighted to welcome Quint Studer. Quint's a true healthcare organizational expert, leadership expert, and a good friend of Caravan Health, and one of my longtime friends as well. Welcome to the podcast, Quint.
Thank you, Greg. Just excited as heck to be with you and all your listeners.
Thanks, buddy. I want to give just a real fast little background for anybody that happens to wander across this podcast today and maybe isn't familiar with some of the great work that Quint and the Studer Group did for so many years. But Quint actually got started as a special needs teacher, got into healthcare at a small Wisconsin hospital, and really made a name for himself through a couple of hospitals, one Holy Cross in Chicago, and then later as a CEO at Baptist in Pensacola. Did turnarounds in both of those organizations, and in Pensacola in particular, drove his employee sat and his patient satisfaction up to the top 1% in the nation. Had lots of organizations from across the country come visit him, trying to learn from him, benchmark against him. And as a result, he formed Studer Group in 2000, really an execution firm that helped more than 1,000 clients improve and hardwire their results in their organization. It won the Malcolm Baldrige Award for Quality in 2010, ultimately sold in 2015. Quint's authored 10 books, including Healing Physician Burnout, and today working with vibrant communities across the country. So, Quint, again, thank you for joining us. I'm gonna kick us off and then lob a question your way, and we'll just go back and forth. But this is Healthcare by the Numbers, and we always like to start out with a couple of things that are measurable in our industry. And so we know that Quint has worked and focused on the nuts and bolts of improving organizational performance. And that's why he's going to be so helpful for us today. I think you'll see not just insight into the numbers we talk about, but I believe you'll walk away with some actual hands-on tools and tips that you could use as you go back to your job. One of the things that we're going to talk about today is physician burnout. I really like to focus on physician burnout, and as much time as we have left, talk about the turnover, especially in nursing in the healthcare industry, but beginning with physician burnout. Some of the data out there is absolutely staggering. Dr. Christine Sinsky, who spoke at our annual symposium last week, mentioned that about half of physicians experience symptoms of burnouts. And the really scary thing about that is it's about twice the rate of the general public, and it's up about 10 percentage points over the last 7 years. Quint and I were talking the other day, and he said, they're an industry that's got this measuring tool called the misery index, and I'm sure he'll talk about that. That misery index is a 4 on a 5-point scale. Maybe that's just a good place for us to start, Quint. I know we want to spend a little time on physician burnout. We'll circle back to some numbers on the nursing side of things, but let's just start with docs. And you and I have worked together a lot. We know that docs sometimes get a bad rap for being difficult to engage or accept change. And they're absolutely wonderful folks who have a very, very hard job, don't they?
I love physicians, and I think actually doctors, change quite readily. If you look at how quick they change when they see a new piece of research, how quick they change when a new data shows that a medication will adjust. I just had a doctor change a little bit of medication I was taking because of new data. So I think doctors are actually quite good at change if they think it's outcome-based, research-based, and it makes sense to them, and it allows them to do what they want to do and love to do, which is practicing medicine. It's the other stuff that they think doesn't fit why they got into healthcare in the first reason was to take care of patients that gets in the way. So in 2014, my sister was actually dying of cancer, and we didn't know we were hoping she'd recover. She had pancreatic cancer. She had a Whipple procedure. Those of you who know what that is. And I was driving back and forth from Pensacola to Tampa, which is about a 7-hour drive, because she had no children. Her husband, who is now passed to, had dementia. I was the only sibling, and my mother said, you go and be with your sister. So for the next 3 months while she was in Moffitt Cancer Center, I would drive to and from Tampa every week. And then we'd trade off with one of her friends, Ruth Ann Miller. And one day I get this phone call from a fella in Houston, or Texas, I think it was Houston, called George Ford. And he's a physician. And he says, Quint, you have a voice, and I'm really concerned about physician burnout. And this is 2014. He said, we've got to get our handle on it. And if you could write some things on it, I think it could be helpful. Well, like anything, when you hear somebody say that, you start diagnosing it deeper and deeper, and talking to George, who educated me a lot. And this physician burnout thing is, so I wrote the book in 2015, Healing Physician Burnout. I think it sort of coincided with me, though, sort of, not being as active in healthcare. So I don't know if I was able to promote it as much. So Healing Physician Burnout, I think, I called it the deadly cancer in healthcare in the mid-2015s. That, if you don't know about something, it comes up and all of a sudden it's too late, like certain cancers. By the time you know you have them, it's stage 4. Well, I think by the time we got to physician burnout, it was stage 4. So yeah, it's been always something I've done a lot of research in, wrote a book in, still all over the place. I'm still very deep into it. I serve on the board of some healthcare systems. And I think now it's even gotten worse, but it's been bad for a long time.
Yeah, I think there's a tendency today to blame a lot of things on COVID, some of them realistic and some of them not. And it would be real easy to say that the front line has really struggled in last year. And there's no denying that that's true, but that certainly isn't the foundation for physician burnout. As you mentioned, it's been coming on for a long, long time. It's such a noble profession. How did we lose some of that nobility in the profession to get us to where we are today?
Well, I think, change is hard, and certain changes are really hard. So if you look at a physician, certainly, and, they're going to tell you, and I agree with them, that, all of a sudden they're doing a lot more work on computers, and not computers with patients, but document records, insurance. I also, in our research, it was sort of interesting because I understand the electronic medical health record. I actually was speaking at conferences before it was ever implemented, talking about why everybody wanted it. It was going to make it easier. We're going to be able to talk to each other. We're not going to duplicate tests. But like anything, something hits the market, you have to adjust it. It's driving while you're in traffic, and that's certainly been an electronic health record. When my sister was in Moffitt, I had a pulmonologist at 9:00 at night just break down because he said he's never worked harder in his life. But according to the RVUs, it looked like he's working less. So I think what happened in our research, it showed, while technology is good, doctors want the technology to make their lives easier. And they see some of the technology as making their life more difficult. So that exacerbates it right now. So a couple of things just on docs. Burnout isn't just a certain age. Our research showed, it really wasn't our research, it was Medscape's research, showed that, between 56 and 55 years of old, 55% of the docs are experiencing some type of burnout. 36 to 45, 51%. Under 35, 44%. Actually, 56 to 65 is 46%. Maybe it's because they think there's a light at the end of the tunnel.
It's retirement.
With the least burnout are the oldest, because they probably think, I only have to do this for another year or two. So that's what's also very concerning. When you have 50% of your people or more that are in the profession not liking it, that's not going to attract the next generation of physicians, because they're hearing about it and say, I don't think so. And you and I have talked. I don't know of any other profession that has a misery index.
Yeah.
But, physician, there actually is a physician misery index. And what that basically shows, once again, is the numbers are staggering with the number of physicians that, basically, I think I have some new numbers right in front of me, seeing this is all by the numbers. Yep. 80% of surveyed physicians find increasingly harder to spend time developing an authentic engagement with each patient. 80% they are personally risked burnout at some point in their career. 96% say they personally witnessed or personally experienced negative impacts as a result of physician burnout. 66% say the challenges of practicing medicine in today's environment has caused them to consider career options. 89% say the business and regulation as healthcare has changed the practice of medicine. So that sort of just shows you that we're at stage 4.
Yeah. You and I did talk the other day. We looked at that together. I appreciate you turning me on to the misery index. I read that same article, and they talk about the definition of burnout. And you taught me along the way that you have to diagnose before you treat. And it mentions in there that the burnout can affect all 3 sort of components of the body. It can be physical, it can be emotional, and it can be spiritual. And the spiritual piece is really the purpose that we talk about so much. And we've lost a lot of that in healthcare. So maybe before we talk about how you treat that, maybe it's helpful to talk a little bit about some of the things that resonate with physicians. So we start to build the concept of how do we start to get our arms around this and begin the journey the other direction.
Well, I think we have to realize, and I think this is good, physicians tend to have a skepticism about them because they have to be skeptical because they want to make sure the new drug, the new procedure, the new technique is proven. So that is a positive trait, not a negative trait, because, you want them to research and be confident in what they're doing. So I think if we're not careful with physicians particularly, and I get it, we want to help them so bad, but the words you hear the most today are stress, resiliency, and mindfulness. And I I understand that. I mean, I've been trained in transcendental meditation. I can do it. I know all about it. And I tell people, so you can tell me to be more mindful, and I think it will help. But if you think mindfulness is going to solve the problem, it'll just help me handle it a little bit better. But I think sometimes, Greg, we just treat symptoms. And I think in physician burnout, we've been treating symptoms. Yeah, train me how to be more mindful. Help me deal with stress techniques. Heck, the Studer Community Institute, which I'm head of now with our not-for-profit, we created a whole toolkit for stress and resiliency. So not that I don't support training in stress, resiliency, and mindfulness, meditation, but I really think we're missing the root cause sometimes. And if we can fix the root cause, then those things become nice to haves, which is where I really want to go.
So if I'm a CEO or a physician leader out listening to this podcast, how do you start to get your arms around this? Where does some of that root cause come from, and what can be some of those early steps that somebody can take to, again, start to turn this around in their own community?
Well, I think it starts, of course, with measurement. It starts with making sure you have good tools in place on a regular basis to measure what physicians feel as the performance, because it comes down to culture. It comes down to creating the right culture for physicians so they feel it's efficient. They feel that it's working for them, that they can take care of patients. So I certainly think measurement is one thing to get a good handle on, because this doc might be another doc. Mm-hmm. I've always liked, I put in one of my books, the quadrant exercise, that you sort of touch your docs in different quadrants. This is a doc who seems to be doing really well, seems to be doing okay. How do we, let's not ignore them, because what we do with any human being, if they're okay, we just sort of leave them alone. Well, if they're okay, then we need to be helping them and talking to them and, still making sure we're connected with them, or maybe they'll go the other way. So that's quadrant 1. Quadrant 2 is docs that are normally pretty good, but there's a couple bothersome things going on. And I don't mean physician behavior. I mean, in general, something's not what it used to be. Quadrant 3 this is a pretty unhappy physician. I mean, there's real concerns. And quadrant 4 is a physician that just if they could exit, they would exit. Yep. So it's interesting, because I was in a healthcare system one day and I asked them a simple question. I said, just out of curiosity, how much revenue is derived from physicians? They looked at me and they said, all of it. I said, well, it's pretty interesting, because I own a minor league baseball team. I think we know more about our season ticket holders that we get $700 a season ticket from than you might know about some of your physicians, because you've got to know your physicians. Probably the best, he's retired now, a hospital CEO I ever saw this was Ed Goldberg at St. Alexis and Hoffman Estate. He knew his physicians so well. So I think you have to know your docs. you have to sit here and seriously look at them and say, they're not, a medical staff is individuals. So what does this individual need? Who's talked to this individual last? And then Greg, I think you have to look at, every doc's a little different, but you got to say, what are their key drivers? You know, does it tell me, doc, when you have a good day? That's the question. When you have a good day, tell me what happens during that day. Because that's the driver. So he might say, or she might say, well, on that day, all the lab tests were there. On this day, the OR started on time. On this day, the staff was all there. On this day, I didn't have any, different things occurring. I told the story the other day because 1999, before I started Studer Group, right before I started, I was speaking to a physician group, and the board said, these are difficult doctors. We want to hear what you say. Well, they had a ton of agency. We're going to get into agency lately, but they had a lot of agency nursing, and their ORs never started on time. So I walked in and I said, how would you like work in a hospital with regular staffing and the OR started on time? And the doc they told me was going to be difficult raised his hand and said, how do we make that happen? So I think it's really, we talk about individualized patient care. I think it's individualized patient relationships. And as you know, one of the things I've always recommended is a preference card. We have a preference card for surgeons doing surgery. Well, why not have a preference card on every doc that tells me, here are the 4 or 5 things that when things goes well, it really, really works. The other thing, and this is now more, I'm going to push the envelope here for people on this podcast. I think the pendulum swung too far the other way. It used to be, well, docs think they're God, or God thinks he's a doc, or vice versa. And the fact that docs get all this preferential treatment, they get this preferential treatment, their own cafeteria, their own parking spot, blah, 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 blah. So I think the pendulum swung to the top, to the thing that the pendulum swung so far over that I don't think we're recognizing these are highly skilled, highly trained, top of the profession people. So I want to just explain this. Now get ready. What other industries treat their highest performers differently? And they don't apologize for it. They don't say this is wrong. Why? Because they know how important that person is. My wife and I were walking in Manhattan one day, and we happened to come across where they were like going to shoot a movie. And they had signs up, and they had these like RVs there. And the RVs had names of the actors and actresses, and they tended to be the stars. Now, they didn't have RVs for everybody, but nobody else sat there and said, why did they get an RV? They're just so dang happy they're in the movie because they're all employed. I own a AA baseball team, and I'm going to explain what it's like if you're a baseball player. Now, if you're a AA baseball player, you're in the minor leagues. You're a couple rungs from the major leagues, but you got a chance to make it. Now, you're probably making $1,500, $2,000 a month, something like this. But that major league team knows that the future of their whole entire franchise is built on these minor league baseball players. So I want to compare how we treat physicians to how we treat minor league baseball players, which only 5% of them will ever play in the majors, but they treat everyone like this. So let me walk through. One, we have to give them 2 nutritional meals a day because the major league clubs wants to make sure they eat absolutely correctly. So we actually provide them 2 nutritional meals a day that are pretty much dictated by what the major league club wants because they want them to be healthy. But you got to remember, they got to be healthy. Because let's compare what they do to what a doctor does. Well, if the game starts at 7:30, they're going to have to go warm up about 7 o'clock. They're going to go out on the field and play a little bit of catch, and they've done some batting cage stuff earlier. But when the game starts, I'm going to bat 4 times. I might see, let's say on average, 5 pitches a bat. So I'm going to have to hit or take 20 pitches, maybe a little bit more, but 4 times. Then when I'm done, by the way, I get to go sit down for a while when I'm done just to rest. Now, then when I go out on the field, remember a game's 3 hours long. I'm saying that's a long game, but 3 hours long. So 90 minutes of that I will be sitting on the bench most of the time, except the 4 times when I go have my pitches. When I'm out on the field, that's another stressful situation. I'm going to be out on the field for maybe an hour and a half, stretched out over 9 innings. So maybe, 10 minutes per inning. I might get 1 fly ball. I might get a couple ground balls. That's it. But I am going to have to be standing up for almost 90 minutes in my job. Now, that's what I'm going to do as a baseball player, major league or minor. Now, let me tell you what else I get. I get an assigned nutritionist to go over what I should be eating and drinking. I get a strength and conditioning coach that's going to work with me. So, standing up for 90 minutes out on the field for a professional athlete could be stressful. So they're going to work with me on how to stand and how to stretch and build my leg muscles up. I'm also going to get a massage or a whirlpool. So somebody's going to worry about making sure I heal correctly. I'm also going to get a particular coach, like I'm going to have a hitting coach or an infield coach or a pitching coach or an outfield coach to mentor and help me. I'm also going to get every player gets assigned a mental health counselor. They call them maybe performance counselor, and they're going to teach me how to handle failure. Because when I strike out, I'm going to be very depressed coming to the dugout, and they prefer me not to beat up the water cooler. So I'm going to have a mental health coach coaching me on how to handle failure. That's how we treat a player that has a 5% chance of playing in the major leagues, because that is our future of our organization. Now, let's talk about how we treat doctors, okay? Pamela Hodel was the surgeon that operated on my sister. It was a Friday. The Whipple procedure was very complex. It's in my book. I dedicated the book to her. The procedure took 13 and a half hours. About 7:30 at night, she came out to the waiting room completely exhausted because she'd been standing for 13 and a half hours. She was also crying because the surgery hadn't gone like they were all hoping it would go. So she emotionally was crying, okay? Now, I don't know what was in the surgeon's lounge, but I bet you there wasn't a nutritional meal there, maybe a cold bagel and some cold coffee. I'm not sure there was a masseuse to give her a massage after surgery. I'm not sure there was a strength and conditioning coach that worked with her on a regular basis so she could stand for 13 and a half hours. I'm not sure that there was a mental health professional that could deal with her on failure. So what I try to bring up is almost every other profession, no matter what it is, figures out everybody's important, but there's certain people that for them to produce, they got to provide a great environment. In Pensacola, Florida, where I live, we have the Blue Angels. There's 6 highly trained pilots, and let me tell you, they get treated extremely well everywhere they go, because those are the people that are going to go up and make those air shows and make people feel great about our country and about the Navy. Now, when I say this, Greg, people will say to me, are you saying that we should treat doctors like we treat these other people? And I say, yeah. They say, well, what if we can't afford it? And I say, I don't think you can afford not to do it, because what are you looking for? You're looking for helping a physician maximize their human potential. So what do they want? Well, I think we have to ask them what they want, and then what we can, what we can't. But normally what they want is efficiency. When you're not efficient, you're showing a lack of respect for me. I tell people a doctor lives in a life of going to the airport every day to being told the plane's going to take off. Now, how many times do you go to the airport, and how many delays will you take before you get a little caustic and a little short-tempered? I've been in airlines, and it doesn't take long for a person to crack just when they've missed their connecting flight. That's what doctors go through every day. So how efficient are you? How standardized are you? Doctors need standardization because they understand that standardization and consistency helps them spend more time with the patient. And they don't think it's standardization and efficiency. They think it's respect and caring. So I know I get passionate, I get emotional. So the goal is if you create a great place for culture where it's running well, Then you're still going to have doctors that are going to be stressed out, that need resiliency, that need mindfulness, but at least you can put your arms around it. Last thing you need is doctors need to hear the good stuff. We tend to only communicate with doctors when we have something negative to say. We don't call the doctor from the pharmacy and say, you're a heck of an order here today. When they come into the OR late, everybody knows doctor's late again. When they're on time, we don't say, hey, it's so great to have you on time when you're here. Doctors don't hear what's right, they hear what's wrong. And I had a Terry Short who wrote a book recently, asked me for a doctor story. And I said, well, here's one that I'll never forget. I was president of a hospital. We did employee of the month, and the staff of the radiology department nominated a doctor. Now, this doctor wasn't employed he had a group that had a contract with us, and they explained that we were a trauma 1 center. We had a bad accident, and all the surgeons, everybody was doing operations. Of course, the waiting room was jammed. This doctor in radiology was leaving the hospital that night, and he saw these people waiting, and he wondered what was going on. He sort of knew there was a bad trauma, but he realized these family members weren't being communicated with because everybody was so busy in the OR. So he became the communication liaison between the OR and the families that night. So they wrote this wonderful note. So we invited him to come to the sort of town hall meeting. He didn't know why he was coming. And when we got there, we named him like our outstanding difference maker for that month. The radiology staff had gotten together, and when they did that, they all ran in and threw glitter all over the room and made a big deal about it. Okay? I got a letter from him a week later, a long letter, said that was the best day he's had in a long, long time. We underestimate what showing impact with physicians does. Another hospital, then I'll be done. For Doctors' Day, they had the staff start writing what doctors mean to them. Then they took those letters up and they put them all over the cafeteria. You know what they found? Doctor after doctor reading those things. We are missing the boat when we don't show more appreciation for physicians.
Thanks for that, Quint. It's when we started this podcast, we said we'll talk about the physician side of this, and equally important is the nursing side. But it's always been funny to me that we separate the two, because it's almost like we don't treat physicians as people. And ultimately, it comes back to a saying that I heard a long time ago. I had a medical records supervisor who told me, we don't care what you know until we know that you care. And caring is sometimes it's relationships, sometimes it's operational things that drive people nuts. But what I heard you say was, you got to look in the mirror a little bit. If you want to make it better, you got to stop doing what you're doing today, and you got to evaluate where you can do something that has an impact from a relational standpoint with whether it's a physician, whether it's a nurse, or anybody else in your organization.
And not make excuses, not all of a sudden come up with well, here's why we can't. You do what you can. You not maybe do everything, but you do what you can. I had a hospital, and I asked them, when was the last time they measured medical staff satisfaction? And they said, well, we haven't done it in a while. I said, well, when was the last time you did it? They said, well, we haven't done it in a while. I said, well, when was it? They said, well, it was about 5 years ago. I said, what was it? They said, well, we're in the 13th percentile, but I said, that's almost like, to me, malpractice. That's like not measuring patient outcomes. It's not measuring anything. So you got to bite the bullet. And I believe like anyone else, physicians are so smart. They know if it's a culture issue or not. And if they know that you're doing everything you can to make it run well, make it run right, they're going to give you a few breaks. Yep. They're going to understand that. They're going to understand in COVID-19 why they have to do these things. They're smart people. We shouldn't underestimate how they connect the dots. And when things are running well, they connect the dots that you care. When things aren't running well, they connect the dots that either you don't care or you're not competent.
Yeah, I think that's a really good point. It's funny to say, my hospital story, and when we started, we were in the 8th percentile of patient satisfaction. And I almost said it was a blessing, because people got to experience the bad and they could relate it to when things got a lot better. And if somebody finds themselves in a situation where they've got physician burnout in their medical staff right now, just trying to do those things to make it better, rounding on your physicians, asking them what they need, trying to deliver the input, the efficiency, the great patient care, the appreciation you talk about. They're going to know that you're taking actions that are going to have an impact on them. You get some points for trying, don't you?
Well, and then bring the outside expert in to talk about something like resiliency or something like that, then it makes sense. Yeah. If you just bring them in and you haven't done these other things, it's almost insulting to the doctors that you don't want to really fix this place. You just want us to go learn how to meditate. And again, I believe in all these things, but it just doesn't work if you're not doing the basics, if you're not treating the root cause. It's almost a little insulting, you know. So if the plane's been late every day and you're telling me instead of fixing the plane, I should go over there and take some pause and breathe, it'll help me. But why don't you just get the dang plane to be a little more on time?
Yep. And you know, I've been blessed in my life, Quinn. I've got to learn an awful lot of things from you. And so much of this, whether it's physicians or nurses or anyone else, it really comes back to the relationship side of things. I remember listening to a CEO from Indiana at one of your conferences who said his change in his medical staff began with the CEO reaching out to one medical staff member a month, and they just went out to supper together. And they didn't even talking about the shop. They wound up talking about family and what do you do in your spare time and what's the first car you ever had. And it broke down some of those stereotypical barriers that we've got. And that's what starts to lead to some of the I care about you, I know you. If I don't know you from a personal level, then you can easily become another number, and it becomes easy to point the finger the other direction.
Also, you recognize the family. Families make great sacrifices for physicians. Now, everyone, certainly with COVID, for example, my daughter-in-law is a nurse, Beloit Memorial Hospital. She's working 6 12-hour shifts. No doubt. This is very, very difficult, all sorts of reasons. But, you know, it is a little difficult even on her husband, who's now got all sorts of things. They got the kids home at school. And, you know, I'm a storyteller. And one of my favorite stories is there was a real tough situation. And one of the intensive care physicians ended up spending almost the whole weekend in the hospital. The nursing staff sent flowers to the spouse and thanked them and said, we know that your spouse was at the hospital all weekend. We know how difficult that is, but we want you to know what a difference he made that weekend with the patients. They sent flowers to this person's home. This person showed up at the hospital and she got the flowers crying because no one had ever thanked her for her. So I think it's a family situation, not an individual situation. So there's a lot of great stuff. You want to talk about employee turnover here as we get into
Let's do a little bit. Let's talk about the differences, because I think there's an awful lot of overlap with things we've talked about. But I'll throw a couple of numbers at you. And again, some of this is COVID related. There's no denying that. But we've had a challenge with nursing turnover in particular for a number of years. And depending on the latest data you see, anywhere from 8 to 38% turnover in certain parts of our country, higher for nursing assistants. The ratio of nurses to patients has diminished. It's a struggle right now. There's no denying whether it's COVID or it's not COVID. It's expensive and it has impact on other things you do in your organization. That's one thing I don't want us to leave without talking about, Quint, is these kinds of things we talk about have impact on other places in your organization, don't they? Whether it's quality or finance, turnover has an impact.
The challenge when you're an executive in healthcare, you read your budgets by line item, and sometimes you miss how line items connect. I certainly did. We had an IV team at one of the hospitals and we had like 12 full-time nurses on the IV team. So around budget time, we decided, well, we have to cut something. So we cut the IV team, dedicated IV team, saying that we'll just train all the nurses to do IVs and then we won't need this dedicated IV team. And we did save money for a while on the dedicated IV team, but we spent a lot of money on it because our infections went through the roof because we didn't have a dedicated IV team. So we didn't do it the right way. We didn't train the nurses the right way. So I think when I got into this, Greg, some people thought they said, well, Quint does soft skill stuff. And that really aggravated me because I think engaging in people is hard. It's not soft. I'd rather do a whole bunch of other stuff that's easier, that's called without people. People's we're relationship business. So again, you look at a turnover. So we're always trying to reduce turnover. And we'd say, well, if you reduce turnover, you reduce overtime. No doubt. When you reduce turnover, you reduce overtime. You reduce use of agency. Again, agency is a necessary thing in healthcare. I'm not against it. It fits its purpose. Sometimes it fits its purpose. There's a place for it. But too much is too much. And so what happens is, but they thought it was soft. And then the Voluntary Hospital Association years ago did a study. They did a study on mortality. And they did the correlation between turnover and mortality data. That's what changed a lot of people's views. All of a sudden, I had data that I had never had before. And here's what it showed. It showed that if you have turnover 24% or more, your mortality rate is way beyond the 1. And for people listening to this, if you're questioning what it is, if mortality severely, acutely adjusted is a 1, it means people that are supposed to die, and people that are supposed to live. If it's below a 1, that means people that are supposed to die, live. Not all of them, but a better percentage. If people that are supposed to below a 1 is people are supposed to live, die, and above the 1, people are supposed to live, die. So when people used to ask me, what should I ask a hospital? I said, ask for their adjusted mortality index. And if it's below a 1, I'd feel a lot better going there. If it's above a 1, I'd be a little concerned. I'm on the board of Tri-Health. The other day, they reported that their mortality index was like a 0.48. I said, my gosh, that's what you should put on a billboard. That's what I'd like to know if people could understand it. Now, what it showed was there was a correlation. So the lower the turnover, particularly below 12, total 12, nursing should always be 8 or 8, 9 area or less. So if it's below 12, had better mortality index. So every piece of turnover that went up, your mortality was impacted. So the question is, turnover is not only about dollars, it's about lives. And I remember working with the CEO one day, and we were trying to work on things to reduce turnover, which was quite high. We talked about peer interviewing, we talked about onboarding, we talked about rounding, we talked about thank you notes, we talked about development. And I could tell he was balking. And I said, and it reminded me years ago at Park Nicolet, when they told me when a doctor doesn't follow the critical pathway, they say, why is your autonomy more important than the clinical outcome of the patient? And he was in a system, and he just didn't want to go along with it. And I said, so you're telling me you would rather not implement these things to lower turnover, so you're okay with more people dying? That's what you're telling me. And from that day on, he changed. So I think we have to realize turnover saves lives, or on the other end, it can actually cost us lives. So once you connect turnover to mortality, then turnover is not a soft skill to get lower turnover. Turnover is a necessary skill to improve clinical outcomes. And Greg, my whole philosophy, whether it's HCAHPS or anything else, I don't even call patient SAT, patient experience. I want to tie everything I can to clinical outcomes. Because once you tie it to clinical outcomes, the values of healthcare workers are so strong that once they connect it to clinical outcomes, they cannot not do it, because they would do anything they could to get the best clinical outcome possible. So our whole goal is to take numbers and tie it into clinical outcomes, which then tie into values.
Yeah, I'd love to find some time and talk very specifically about the employee experience piece of it, because you've done so much wonderful work there. But for, again, somebody who might be listening here and saying, well, my nurses can go and make $5 more an hour over here, that's just the world we live in. What are those things that you would point them to that can start to make that difference in that culture and that experience for them and the organization today?
Well, first of all, they have to realize the issue could be them. It's sort of like when somebody gave me a decal one day and told me to put it on my mirror and it said, you're looking at the problem. People love to do those excuses. Oh, they just ran there for $2 or $3. That's an insult to the nursing profession or the healthcare profession. People don't run for compensation. Now, you do to ask yourself the question, are you paying market? Are you value-driven payment? Because then that's different. And most healthcare providers are. Greg, I've spoken for years and asked the HR person, is your compensation market? Most of the time they say yes. So don't fall in the trap of just thinking somebody ran for a few bucks. So first of all, again, everybody's a little different, but I use research. So what do people look for in the job? Number one, they sort of want to feel they're working in a place that's moving in the right direction. So you have to really communicate. As a CEO, you have to, or anyone, you have to communicate that we're doing the right things. We're moving in the right direction. We know what we're doing. That's why I love Caravan Health, because I think you bring so many best practices to these hospitals that would not normally be able to access these best practices, and for like-size hospitals too. So I think they have to all move in the right direction. But then it goes down to some simple things which aren't so simple. Do you care about me as a person? Now, of course, some people are going to want that more than others, but do you care? Do you know what's going on in my life? Gallup says the number one, people don't leave their job, they leave their boss. And the question number one is, do you care about me? Now, here's some other things. Do I have the system? Do the systems work? I always say, if I'm an ER nurse, I can be as passionate and motivated as heck, but if every day I come in, the systems aren't working, I'm going to eventually lose that passion, because you're making withdrawal from my emotional bank account, because here I am giving it my all, and you just can't get things to run correctly, which I know is impacting patient care. So how are the systems running? Whether it's IT, whether it's lab, whether it's SPD, how are the systems running? I'm going to ask, do you have the tools and equipment to do the job? And I'm going to give everyone a one question one if they don't want to ask all these, but do you have the tools and equipment you need to do your job today? Today, because I want to know. And if you do, yes. And if you don't, I want to deal with it. Even if I can't get it, we're going to talk about it. But I think most of the time, Greg, we play defense in leadership, not offense. So we wait till somebody comes to us. But if we go out, I think everyone, if they would do this today, just walk up to every staff person for the next week and say, do you have what you need to do your job today? I bet you 90% of the time they're going to hear the word yes, but they don't think that because you only hear it when it's not. I will probably ask something like, hey, I want to recognize some people. Are there any of your coworkers that I could recognize? So those are some key things. Now, a couple other things that maybe aren't everyday thing. People want to get feedback. They want to be rewarded and recognized, and they want to be invested in. In my book, Busy Leaders Handbook, I talk a lot about younger employees. Younger employees are great, but they really want to be engaged, and they want to be invested in because they want to learn. Everybody does. So I think there's some quadrants. Number one is care. Number two is, I'd say, operational issues such as systems running, tools and equipment, and who should I recognize and things like that. Then the other one I think is the last one, which is really ties into feedback, reward and recognition, and development. I was touring a hospital today, and the CEO said to me, my CNO is a rock star. I think she's not going to be here long. He said, she'll be here forever if you treat her right. Hospital people know which hospitals suck and which ones don't. They all talk, and they're going to talk. And if you give her the right culture, she's going to stay with you. Now, what is the right culture? She wants to be challenged. She wants to have new opportunities. She'll be with you. So don't fall into this trap that she'll go to a bigger place. She'll go to a bigger place if she feels she's not being fulfilled in her current place. And what happens, Greg, is leaders fall into the trap of always, because when people does an interview, when you ask somebody why they're leaving, they're not going to say because you don't care about me, the systems aren't working, the tools and equipment I don't have, I never hear anything good, and you don't fire these people that are sucking the life out of me on a regular basis. That's why they leave, but they're not going to say it. They're going to say, I have an opportunity I just can't pass up. That's why I like using outside companies to do exit interviews. Years ago, Gap was losing people, and they did their own exit interviews. And everybody said, it's compensation benefits. All these people are leaving because of compensation benefits. So they raised their compensation and benefits, and everybody was still leaving. So then they hired an outside company to start talking to people that had left. They said, no, comp and benefit was fine. I just didn't like my boss. So I think we've got to really dig into the data to figure out what people want. Healthcare people are great people. They're value driven. They also don't like to leave because they hate the fact of starting over. Because what do they want? They want to be efficient and effective because they want to get great clinical outcomes. So in my work on change, I show that high performers actually don't want to leave because they don't want to start over because they love being at the top of their game. And when you start over, you're learning new things and you go backwards a little bit.
Very good, Quint. I always learn something when I listen to you, and it just reminds me of, we talk sometimes about why everybody doesn't do this, and we sometimes say it's because it's viewed as soft. I think maybe we've come to realize that it's viewed as being very hard. I appreciate your tips today. I will tell anybody that out there that if you're looking for more of what you heard today, you want some detail, you want a little game plan. For me, Hardwiring Excellence is still the best leadership book that was ever written, and it's a game plan for you. So pick it up if you haven't seen it. Quint, I just thank you for joining us on Healthcare by the Numbers. Any last thoughts or comments before we go?
Well, I want to thank Caravan Health. I've been a big fan of Lynn and the company almost since the beginning. I started out at a 35-bed hospital. I get how hard that is. The resources that give, even if you're a small hospital in a big system, you're a little bit different. And the fact that you understand smaller organizations, the fact that you can bring best practices to me, the fact that you can bring some things to me that help me be more sustainable, both operationally and financially, truly means that, to me, Caravan Health stands for what Hardwiring Excellence talks about. Caravan Health has great purpose. You do such worthwhile work, and you make a difference. So thank you.
Thank you, Quint. I thought about you that not long ago, we were in Tampa, Florida, kicking off for some physicians. And one of the things that we do that you just sort of alluded to is that we help physicians take some of that administrative burden off their plate. We try to coach to a team environment and everybody at the top of their licensure. And so we had a group of 40 physicians, and we went through this and we said, we're going to make your life easier. We're not giving you one more thing. This will take things off your plate. And after we got done, one of those physicians came up to our table and she was crying. And we thought maybe we had offended her or something. We asked her what was wrong. She said, nothing wrong. She says, you just gave me hope. Yeah. And I think that's what a lot of folks are looking for right now is hope. They're looking for leadership, and it's out there. So thank you, Quint. It's always a pleasure to get a chance to talk to you, my friend.
Thank you.
For those in the audience that would like a little bit more, Quint, he is literally all over the place. You can find him out on LinkedIn. He's got his own regular podcast. You can go to quintstuder.com. He's on Twitter at Quint_Studer. Of course, his books that we mentioned, Busy Leaders Handbook, The Hardwiring Excellence, all out there as well. He's also doing an awful lot of work with building vibrant community. And so you can see that work out online as well. For Caravan Health standpoint, if you'd like to know a little bit more about us, go to Twitter, LinkedIn, Facebook, username at Caravan Health. And you can sign up for our newsletter at www.caravanhealth.com as well. To tune into past and future episodes, you can go to caravanhealth.com. Thank you for joining us for today's episode, and thank you again, Quint.